This is part 2 of the cardiac conduction cycle. So, the autonomic nervous system plays a big role in controlling the pulse. And these are different things that can affect the pulse. So, the autonomic nervous system has the cardiac control center in the medulla oblongata. If you have positive chronotropic agents, these are things that raise the heart rate. So, chronotropic just means it changes the heart rate, positive means in a higher manner. So, it increases the heart rate. They have cardiostimulatory effects from the sympathetic nervous system. And these go through the cardiac nerves in the T1 to T4 area. And cardiostimulatory just means that it stimulates the cardiac area. So it's going to raise the heart rate. Negative chronotropic agents have the opposite effect. They change the pulse, but they lower it. And they have a cardioinhibitory effect, meaning it inhibits cardiac response from the parasympathetic nervous system, and this is through the vagus nerve. Think back to Anatomy 1, parasympathetic and sympathetic nervous systems. Remember, the sympathetic is your fight or flight. It's going to increase everything important to survival. Heart rate is one of those things. If you're running from a bear, your heart rate is going to increase, right? You need more oxygen. You need your blood to flow faster. You can get your oxygen to all those muscles to make energy so you can keep running from this bear so it doesn't eat you, right? That is your sympathetic. Increased heart rate. It has cardiostimulatory effect, stimulates the heart. Parasympathetic is your rest and digest. So you're not running from this bear anymore. Okay, you're not dead. You're not worried about dying. The parasympathetic nervous system is going to kick on and slow everything back down. Decrease your heart rate, decrease your breathing rate, decrease your temperature. It's going to slowly turn back on your digestion. And your kidney filtration, your liver filtration, all those things that were not important to survival immediately, right? So that is your parasympathetic. So that is going to turn on your rest, slow down your heart rate. And this is through the vagus nerve. Remember, the vagus nerve is the one that if you stimulate too much, it can cause you to pass out because your heart rate drops, you bottom out. So that's through the vagus nerve. Vagal tone is what holds your heart rate between 70 and 80 beats per minute at rest. So the vagus nerve maintains a slower heart rate than the pacemaker actually sets. It should be at like 100, right? But the vagal tone from the vagus nerve lowers it because it has cardioinhibitory effects. So autonomic nervous system and all of its important things. And this is really, really important to nursing because whether you realize it or not, medications affect the autonomic nervous system. So there are a lot of medications that are not supposed to have an effect on the heart, but because they affect the autonomic nervous system, it can have an effect on the heart by either increasing or decreasing the heart rate. So it's really important to understand how the autonomic nervous system regulates heart rate. So heart rhythm and concentration are controlled by the cardiac centers in the medulla, which is in your brainstem. The SA node, or the pacemaker, fires to start the process of your heartbeat, right? The autonomic nervous system can stimulate depolarization of the SA node to occur more or less frequently. So it can control the depolarization, how often it happens, which in turn controls your heart rate in a sense, right? So this causes it to fire more or less frequently. Do we need to speed up or slow down the heart rate? The autonomic nervous system can stimulate depolarization in the cardiomyocytes to increase contractibility. So it can make your heart contract harder. So it can make your heartbeats more efficient. Every time your heart beats, it can squeeze harder and pump more blood. Without the influence from the cardiac centers, the heart has an intrinsic firing rate of at about 100 beats per minute, like I said a minute ago. Your SA node fires at about 100 beats per minute. And your vagus nerve is what slows it down and holds the vagal tone to cause it to be 70 to 80. So somebody that has damage to the vagus nerve is going to experience elevated heart rates just because they don't have that vagal tone anymore. It plays a really important role in keeping the beat a little bit slower and making the heart contract a little bit harder so it's very efficient with its pumping. Sympathetic nerves are going to increase the heart rate and contraction strength because remember, the sympathetic is your fight or flight. You're running from a bear, your heart is going to be really, really hard and really, really fast, right? So your sympathetic nerve fibers are going to increase your heart. The pathway to the heart sympathetically is going to be in your T1 to T4 of your spinal cord, and those are your cardiac nerves. T1 to T4 is in the chest, right top of the chest. The first to the fourth vertebrae space in your chest, right around your heart area. Nerves pass through the cardiac plexus, which is, like the big branch. All the nerves branch into one big nerve, and that's the cardiac plexus, in the mediastinum of the chest. And then they're going to continue into the heart. So they come off the spinal cord as one big nerve, the cardiac plexus, and then it splits into the four, and it goes into the heart. The fibers are going to terminate in the SA and the AV nodes, in the atrial and ventricular myocardium. So remember, the SA and the AV nodes are the two electrical signal senders, right? The SA node is a pacemaker that starts the signal of the heart. The AV node is the one that continues the signal through the heart. And remember, if the SA node is not working, the AV node can start the heart signal on its own. It's just not really effective or efficient, right? So these cardiac nerves go right into the SA and the AV node directly off the spine, and they come from the cardiac control center of the medulla. Okay, and these are the sympathetic ones, the ones that speed everything up. So if they're innervating the SA and the AV node, they can speed up the signals that are sent to allow the depolarization to happen quicker or slower. So your parasympathetic nerves that slow the heart begin in the vagus nerve in the medulla, and then they extend to the cardiac plexus, and then they go to the same way to the SA and the AV nodes, just like the regular ones, or just like the sympathetic nerves. The fibers of the right vagus nerve control the SA node, and the fibers of the left control the AV node. So they split into right and a left, and they control the two different nodes. There is little or no vagal stimulation of the myocardium. So the vagus nerve does not have the ability to make the heart contract less strong, like weaker. But it does have the ability to slow down the firing of the SA and the AV nodes. So sympathetic can speed up and make it contract harder, but the parasympathetic can only slow down. It doesn't have an effect on the contraction because it doesn't put any nerves into the muscle of the heart. But the sympathetic does. It goes to both nodes and muscle. So how does the sympathetic nervous system actually affect the heart? So the sympathetic fibers release norepinephrine. Okay, norepinephrine binds to B1 receptors in the heart. These activate and open the calcium channels in the cardiomyocytes, or the muscle cells, in the SA and AV nodes. Okay, this causes depolarization to happen. It increases heart rate and contractility. This can increase your heart rate up to 230 beats a minute, which is not good. You probably would be dead. But at an excessively high rate, anything greater than 180, diastole becomes too brief for adequate filling. So if your heart is beating more than 180 beats per minute, diastole, or rest, is not happening long enough to allow the chambers to refill with blood, meaning when it does beat and squeeze, it's not squeezing or beating out any blood. There's no blood in there to squeeze. So anything over 180, you're not adequately pumping blood, you're probably going to die. And 230, even though it has the ability to fire 230 beats a minute, it's not going to happen because you're going to die within a few seconds, maybe a minute, because you're not getting any blood anywhere. You're going to have a stroke, you're going to have a heart attack. So this is a sympathetic nerve fibers, and it releases norepinephrine, which is epinephrine, speeds everything up, and it binds to the B1 receptors of the heart, which allow the calcium channels to open, allowing that calcium to flow in to cause depolarization. So parasympathetic vagus nerves have cholinergic or inhibitory effects. So anything that's cholinergic just means it inhibits or stops or slows down something. So it has inhibitory effects on the SA and AV node, not the cardiac cells. Remember, it doesn't have any effect on the muscle cells. It doesn't do anything with contractility. It's just the beat and the pace, right? So it has acetylcholine, which binds to the receptors that open potassium gates in the nodal cells. Potassium leaves the cells quicker, making it hyperpolarized, making it fire less frequently because it's more polarized. It has to raise the voltage more from the negative. So instead of it being negative 70, maybe it's negative 90 now. And it just takes longer to repolarize for it to fire more frequently. This slows down the heart rate because it's just harder to reach that level of polarization. It takes it longer, it's a little bit slower. Why is this information important? Why do you need to know this? Medications. Medications and the effects they have on the heart, specifically cardiac medications. So if you're going into nursing or anything cardiac related, like a cardiovascular technologist, you're going to deal with people that are on heart medications. Nursing, I would guess that about 75% of your patients, from my experience, are going to be on some kind of cardiac medication. If you're dealing with geriatric patients or elderly working in a nursing home or an ALF, I would say 95% of your patients are going to be on some kind of cardiac medication, whether it's for blood pressure, for heart rate, anything like that. Somebody's going to be on it. You're going to deal with it probably every day in your career. So when we're looking at cardiac medications, we need to determine how the medication is going to affect the heart by asking the two questions. What does this medication chemically do inside the body? And what does that chemical reaction cause the heart to do differently? So the first medication is beta blockers. Beta blockers are any medication that ends in OLOL. And if you look at OLOL backwards, you flip it, it looks like BB, like little b, little b. That's a beta blocker. So beta blockers block the B1 or the beta receptors. And we just talked about these. They allow the norepinephrine to bond to them, and then that allows the calcium channels to open, causing the heart to depolarize quicker. If we block these, the heart is going to depolarize slower, thus slowing down the heart rate. Parasympathomimetics mimic the parasympathetic nervous system. It's a really, really hard word to say, right? It just mimics the parasympathetic. So it acts like the parasympathetic nervous system. Parasympathetic nervous system slows everything down, right? So these pills are going to slow down the heart rate. Calcium channel blockers block the channels that allow calcium in. Works very, very similarly to the beta blockers, but instead of blocking the beta receptors, they block the actual channel. And again, it slows down the heart rate because it causes it to depolarize slower. Digoxin increases intracellular sodium, which speeds up depolarization to allow calcium to come in faster. So digoxin usually increases the heart rate and the efficiency of the heart. It usually makes the heart contract a little bit better. It improves the contractility of the heart, makes the heart rate more steady and strong. So it increases the overall working efficacy of the heart. Sympathomimetics mimic the sympathetic nervous system. So they're going to increase the heart rate. They're going to act like the sympathetic nervous system and make your heart rate beat faster. And vagolytics are going to reduce vagal tone. So if you have too strong of a vagal tone and it's lowering your heart rate down to 50, we need to reduce that vagal tone and let up on it a little bit. So vagolytic medications are going to release the vagal tone a little bit, so it lets the SA node fire more frequently to increase your heart rate so you can beat a little bit faster than you are on your own. So cardiac glycosides is just a class of medicines that treat irregular heart rates or failure of your heart to maintain its heart rate. So you have chronotropics, which work on heart rate, and these affect the SA node. So it's going to make it either fire more or less, positive or negative. Positive is more, negative is less. Those are chronotropics, so it's heart rate. There's inotropic, which is contractility, so those are going to affect the muscle, make it contract harder. It's really hard to make the heart muscle contract weaker or less hard because remember, the vagus nerve does not innervate the muscles. So you usually take inotropics if you need to increase your contractility of the heart. There's no use for that with decreasing. Dromotropics increase conduction, and these are usually targeted for the AV node because conduction issues are usually like heart blocks or something where the SA node is firing but the AV node is not receiving or picking up that signal or sending it properly through the rest of the heart. So dromotropic medications work on that. And then there's bathymotropic, which increase the excitability of the heart, which just allow it to depolarize easily. And it can usually increase the heart rate because the SA node can fire more quickly. So, how do certain conditions affect the heart? So, just like the medications, we're going to ask a few questions. So, to determine how the condition is going to affect the heart, we need to ask ourselves, what does the condition do chemically inside the body? And how does that affect the heart? Like, what was the significance of that thing? So, it's usually electrolytes that we're talking about here. So, what does that electrolyte do to the heart? And what does this condition do to that electrolyte? So, the first one we're going to talk about is hypercalcemia. So, too much calcium. It's going to cause a slower heart rate, but stronger and longer contractions. Hypocalcemia is going to cause weaker contractions and a faster heart rate. Hyperkalemia is going to cause the myocardium to be less excitable. Your heart rate's going to slow down and become irregular. Hypokalemia is going to cause the cells to be hyperpolarized, require increased stimulation, which is going to cause an increased heart rate and probably arrhythmias. So when we think about these electrolytes and what they do to the heart, we need to remember the electrical conductivity and what the role of each electrolyte is in that cycle. And then if we have too much or too little, it's going to change the electrical conductivity of the heart. And it usually changes how easily the heart can be stimulated. It changes repolarization and depolarization rates, so it can affect the heart rate. So take into consideration these conditions, but remember that they're affecting electrolytes, and think about how the electrolytes affect the heart's ability to beat. Just a quick review of heart sounds from last week. Again, auscultation means listening, right? And then you have the S1 and the S2 sounds. The S1 is the first sound, and it's the louder and longer lub sound. And it occurs when the AV valves or the tri and the bicuspid valves close. The second sound is the S2 sound, and it's the closing of the semilunar valves or the aortic and the pulmonary valve. So S1, S2, it's the thump thump, the lub dub. Just reviewing that. I know we talked about this last week, but just review because it's important for the cardiac cycle. So the phases of the cardiac cycle, there are 4. The first one is ventricular filling, and it's during diastole. And remember, diastole means rest. I remember it because diastole, it sounds like die. What do you do when you die? Well, you're resting, right? So if the heart's in diastole, it is resting. So ventricular filling happens during diastole because the ventricles can't fill if they're pumping, right? They need to rest and open up so the blood can flow into them. Then there's isovolumetric contraction. That's during systole. If the heart is contracting, it's during systole. That means it's actively working. It's not resting, right? Then there's ventricular ejection, which is also during systole because it's contracting, it's ejecting blood. And then there's isovolumetric relaxation. The heart's relaxing. It's diastole, right? So those are the 4 phases in that order. The ventricles fill, and then there's a contraction, there's an ejection, and then it relaxes right before it refills. The entire cardiac cycle, all 4 of these phases, is completed in less than 1 second entirely. And we'll talk about each phase and exactly what happens in them. All right, so phases of the cardiac cycle. So let's talk about ventricular filling because that's the first phase. So ventricular filling occurs during diastole because if the ventricles are filling, they are not contracting. It's not systole. They have to be resting, right? It's diastole. So the ventricles expand and allow their pressure to drop below that of the atria because remember, more volume, lower pressure, right? We just increased the volume, so the pressure dropped. So ventricles relax and expand, pressure drops, the AV valves open happily, and the blood from the atria trickle right down into the ventricle. Okay, the filling is going to occur in 3 phases. There's rapid filling, which is the first 1/3 of the blood, really, really fast, easy. Then there's diastasis, which is the second third of the blood. It gets a little bit slower because the ventricles are getting kind of full. And then the P wave happens after this, which makes the atria contract, and then it pushes the rest of the blood, the last 1/3, into the ventricle. So about 2/3 of the blood fills because of pressure drop and gravity, and then the P wave happens to make the atria contract, and then the rest of the blood goes in with atrial contraction. And that's the first phase of the cardiac cycle, and it includes ventricular diastole and atrial systole. Phase 2 of the cardiac cycle is isovolumetric contraction. So the atria repolarize, relax, and remain in diastole for the rest of the cardiac cycle. Their job is done. They push the blood into the ventricle. Now they just need to chill and refill, right? So they're going to sit there, repolarize so they can contract again when they're ready, and rest in diastole. Okay? The ventricles then depolarize, causing the QRS complex, and they begin to contract. The AV valve closes between the ventricles and the atria because we don't want the blood to go back up, right? And then the heart sound S1 occurs at this point because valves close. All the valves at this point are closed. The AV and the pulmonary and the aortic valve, they're all closed. The semilunar AV valve, they are all closed. The ventricles start to contract, but because all of the valves are closed, blood cannot leave the ventricle. It's stuck in there. All the doors are closed. So it's called isovolumetric because the volume of blood in the ventricle stays the same. Iso means same, no change in volume. So the ventricles are squeezing, yes, but volume of blood inside of them is not changing. It's isovolumetric. The pressure in the aorta and the pulmonary trunk are still greater than those in the ventricles because there is still blood in them from the last beat. The cardiomyocytes exert force, but with all four valves closed, the blood can't go anywhere. So the cells are squeezing, the heart is beating, but guess what? Nothing is happening. Can't get the blood out. That's phase 2, isovolumetric contraction. And when you think about it, just remember isovolumetric means same volume of blood. So the heart's contracting, but nothing is leaving. So everything is closed, blood can't come out. The third phase of the cardiac cycle is ventricular ejection. So this is when the blood does leave the ventricles. So this happens when the ventricular pressure is higher than that in the aorta and in the pulmonary artery. So the squeezing of the ventricles or the contraction causes the pressure to increase so much that it pushes those valves open. So the aortic and the pulmonary valves are pushed open from pressure. The pressure peaks in the left ventricle at about 120 millimeters of mercury and then 25 in the right. And remember, the left is always going to contract way harder because it has way further to go, right? So pressure is way higher on that side of the heart. At first, it's rapid ejection, so blood spurts out really, really quick because that pressure, the seals burst and the pressure is released. And then it's going to slowly slow down. The slower or the further after you get from the busting open of the valves, the slower the blood flow is going to get. It's going to be reduced ejection, slower flow with lower pressure. And then this is going to last for about 200 to 250 milliseconds. This corresponds to the plateau on an EKG, so the part where there really isn't any change in the electrical conductivity. The T wave of the EKG is going to occur late in this phase, and then the stroke volume should be about 70 milliliters, meaning you should be pumping out about 70 milliliters of blood each cycle in ventricular ejection. And if you think about ventricular ejection, the ventricles are contracting, so it has to be in ventricular systole. And then remember, the atria are in systole the whole rest of the cycle, except for during ventricular filling, right? Or they're in diastole the whole rest of the cycle, except for during ventricular filling, they do systole briefly. So ventricular systole is when it's contracting. So this phase is ventricular systole. It's actually contracting. It's not resting. And then phase 4 is isovolumetric relaxation. So the T wave ends and the ventricles begin to expand again. So they're starting to relax and open up again. Blood from the aorta and pulmonary trunk briefly flow backward, pushing on those valves, closing them. And that's when you hear the S2 sound, right? Because the semilunar valves are closing. This creates pressure rebound that appears on artery pressure. So if you're measuring artery pressure, you will see it at this point. Isovolumetric, it's considered isovolumetric because the semilunar valves are closed and the AV valves have not yet opened, meaning blood is not entering or exiting the ventricles. AV valves are closed and the semilunar valves are closed. So the ventricles are basically empty and they're sitting there empty and nothing is changing. When the AV valve opens, the bi and the tricuspids, when they open and then the atria will let the blood flow down into the ventricles again. And then that will start the cardiac cycle all over again with phase 1, which is ventricular filling. So how long does this whole cycle last? So atrial systole lasts about zero point 0.1 seconds. So the atria contract, 0.1 seconds, done. It's really fast and over with. Ventricular systole lasts about zero point 0.3 seconds. The quiescent period, when all four chambers are in diastole, or the quiet time, when all four chambers are nice and resting, lasts about 0.4 seconds. So the total duration of the cardiac cycle is about 0.8 seconds in a heart beating 75 beats per minute. And that makes sense because if there's 60 seconds in a minute and we're beating more than one beat a second, obviously we have to do the whole cycle in less than a second, right? So it's about 0.8 seconds for your heart to do all four of those steps. It's pretty quick and it's pretty efficient in the way that it works.